The stories surgeons tell one another are often about the shock of the unexpected, the bayonet in San Francisco, the cardiac arrest when all seemed fine, and sometimes about regret over missed possibilities. We talk about our great saves, but also about our great failures, and we all have them. They are a part of what we do. We like to think of ourselves as in control, but John's stories got me thinking about what is really in our control and what is not. In the 1970s, the philosophers Samuel Gorovitz and Alasdair MacIntyre published a short essay on the nature of human fallibility that I read during my surgical training and haven't stopped pondering since. The question they sought to answer was why we fail at what we set out to do in the world. One reason, they observed, is necessary fallibility. Some things we want to do are simply beyond our capacity. We are not omniscient or all-powerful. Even enhanced by technology, our physical and mental powers are limited. Much of the world and universe is and will remain outside our understanding and control. There are substantial realms, however, in which control is within our reach. We can build skyscrapers, predict snowstorms, save people from heart attacks and stab wounds. In such realms, Gorovitz and MacIntyre point out, we have just two reasons that we may nonetheless fail. The first is ignorance. We may err because science has given us only a partial understanding of the world and how it works. There are skyscrapers we do not yet know how to build, snowstorms we cannot predict, heart attacks we still haven't learned how to stop. The second type of failure the philosophers call ineptitude. Because in these instances, the knowledge exists, yet we might fail to apply it correctly. This is the skyscraper that is built wrong and collapses, the snowstorm whose signs the meteorologist just plain missed, the stab wound from a weapon the doctors forgot to ask about. Thinking about John's cases as a small sample of the difficulties we face in early 21st century medicine, I was struck by how greatly the balance of ignorance and ineptitude has shifted. For nearly all of history, people's lives have been governed primarily by ignorance. This was nowhere more clear than with the illnesses that befell us. We knew little about what caused them or what could be done to remedy them. But sometime, over the last several decades, and it is only over the last several decades, science has filled in enough knowledge to make ineptitude as much our struggle as ignorance. Consider heart attacks. Even as recently as the 1950s, we had little idea of how to prevent or treat them. We didn't know, for example, about the danger of high blood pressure, and had we been aware of it, we wouldn't have known what to do about it. The first safe medication to treat hypertension was not developed and conclusively demonstrated to work until the 1960s. We didn't know the role of cholesterol either, or genetics, or smoking, or diabetes. Furthermore, if someone had a heart attack, we had little idea of how to treat it. We'd give some morphine for the pain, perhaps some oxygen, and put the patient on strict bed rest for weeks. Patients weren't even permitted to get up and go to the bathroom for fear of stressing their damaged heart. Then everyone would pray and cross their fingers and hope the patient would make it out of the hospital to spend the rest of his or her life at home as a cardiac cripple. Today, by contrast, we have at least a dozen effective ways to reduce your likelihood of having a heart attack. For instance, controlling your blood pressure, prescribing a statin to lower cholesterol and inflammation, limiting blood sugar levels, encouraging exercise regularly, helping with smoking cessation, and if there are early signs of heart disease, getting you to a cardiologist for still further recommendations. If you should have a heart attack, we have a whole panel of effective therapies that can not only save your life, but also limit the damage to your heart. We have clot-busting drugs that can reopen your blocked coronary arteries. We have cardiac catheters that can balloon them open. We have open-heart surgery techniques that let us bypass the obstructed vessels. And in some instances, we've learned that all we really need to do is send you to bed with some oxygen, an aspirin, a statin, and blood pressure medications. In a couple days, you'll generally be ready to go home and gradually back to your usual life. But now the problem we face is ineptitude, or maybe it's eptitude, making sure we apply the knowledge we have consistently and correctly. Just making the right treatment choice among the many options for a heart attack patient can be difficult, even for expert clinicians. Furthermore, whatever the chosen treatment, each involves abundant complexities and pitfalls. Careful studies have shown, for example, that heart attack patients undergoing cardiac balloon therapy should have it done within 90 minutes of arrival at a hospital. After that, survival falls off sharply. In practical terms, this means that within 90 minutes, medical teams must complete all their testing for every patient who turns up in an emergency room with chest pain, make a correct diagnosis and plan, discuss the decision with the patient, obtain his or her agreement to proceed, confirm there are no allergies or medical problems that have to be accounted for, ready a cath lab and team, transport the patient, and get started. What is the likelihood that all this will actually occur within 90 minutes in an average hospital? In 2006, it was less than 50%. This is not an unusual example. These kinds of failures are routine in medicine. Studies have found that at least 30% of patients with stroke receive incomplete or inappropriate care from their doctors, as do 45% of patients with asthma and 60% of patients with pneumonia. Getting the steps right is proving brutally hard, even if you know them.